Thank you everybody for joining us today. Abdullah Hanoun is presenting orthopedic appliances for the FRCS Part 2. There's a Part 1 already on the YouTube channel. Please feel free to review that as well. I feel this is an important topic because one of these appliances and or concepts does come up in the exam generally at one of the tables, one way or the other. Abdullah has just finished operating. He's still actually, he's joining us from the hospital after he descrubbed. You can actually see the markings on his face from his level 2 PPE, so please excuse his voice, he's a little dry. Thank you very much, Abdullah.
Okay. Thank you, everyone, and thank you, Shwan, for your nice presentation. Okay, so the title is Orthopedic Appliances, but in reality, it is appliances and processes. I said too, although if you look at the YouTube, you wouldn't find orthopedic appliances #1. The reason is, this is a continuation of the same topic that our mentor colleague Samir started with theater design. So you will find a lot of the same concept, well, not same concept, the other concepts covered by Samir, and this is a continuation of the same. So let's imagine this scenario. You are a consultant, and on your list there is one patient who had one side of suspected septicemia and the other side, as you can see, a metal work protruding with potential for infection, and you are planning to take that metalwork out and do debridement and washout. Now, if you start thinking about the equipment and the things you are going to use for these two operations, it is, if you are in the exam and the examiner presents this scenario to you, you will start talking about, I will consent the patient, make sure that the patient is marked consented, WHO ready, and then I will take him to theater and I will start scrubbing. He can interrupt you and say, okay, tell me about scrubbing. And then you will say, okay, and after finishing that, I will put him in a drape. Okay, tell me about the drapes. So all of these concepts and things that you do in every single day are fair game in the exam. They can interrupt you during any case or any scenario and ask what it looks to you like a silly question, and then they follow it deep to find how much you know about the things you practice daily. And as you can see, this is taken from the curriculum, orthopedic curriculum. You are expected to reach level 4, which is you know specifically and broadly about these processes and instruments like tourniquet, sterilization in theater and out theater, infection prevention and control in theater and out, warming method and rationale, skin preparations, and extension, anything that you do in every day in theater. So the previous topic, the previous lecture covered theater design, patient's warming techniques, skin preparations, masks and gloves, mechanical DVT prophylaxis, which was covered during the DVT talk, and cement, which usually is covered during adult pathology or properties. Today, I will be talking about tourniquet. I will touch on the surgical drapes again. I will talk about autotransfusion devices, image intensifier, diathermy, pressure irrigation, Plaster of Paris, imagine it, and sterilization techniques. I hope that in the future we'll be cover the rest of the following topics and whatever comes that we feel is important and may come in the exam, like wound dressings, vac pumps. So let's start with the tourniquet. So what is the tourniquet? The aim of this is to give you pointers to how you phrase your answer in the exam. So they may put a picture of a tourniquet in front of you and ask you, tell me about it, or you would say, and I will use a tourniquet, and then they will stop the whole scenario and ask you, tell me about tourniquet. So you have to have a structure in your head, and always start by definition, and then benefits, risks, and complications. Okay? And then you describe how you use it. So for this, I'm just going to give you pointers. So what is a tourniquet? It's a pneumatic device, mostly, used to block or to stop the blood from the field, giving you a bloodless field, allowing visualization, and it has a benefit of aiding in cement interdigitation. okay? And then we talk about the special things you apply during the, when you do the tourniquet. So you say there are different types of tourniquet, but by far the most common one is the pneumatic type, which we use in theaters and in clinics. And the principles are you apply it over the upper arm or upper leg, and you apply padding, which is 2 layers of padding, and then you talk about the size of the cuff, the principle of applying it, which is for the shortest time and lowest pressure possible. You mentioned alternatives, or different types of tourniquets, which are contoured tourniquets, which you can use for special shape of the limbs. There will be some discussion about when do you give the antibiotics, and the antibiotics are given 5 minutes before inflation. And then before inflation, you have to exsanguinate the blood. And you do that by using either exsanguinator, S-mark bandage, or simple elevation. And the pressure is 100 millimeter mercury above systolic in the upper limb and 50 in the lower limb, and 50 in the upper limb. And time limit is 120 for the lower and 90 for the upper. What happens if the operation takes longer than that and you still want to use the tourniquet? You can say, I will deflate it for 10 minutes, but the best answer is for 1 minute per 10 minutes of previous use. So if you used it for 60 minutes, you can deflate it for 6 minutes, and so forth. Okay? When cannot you use a tourniquet? Any condition that is exacerbated by stoppage of blood. So vascular disease, sickle cell disease, AV fistula, diabetes sometimes, which is relative contraindication, because we know that we use it. The only reason we say it is because of the calcification of the vessels will make it not that effective. In local anesthesia, you can still use the tourniquet, but you have to warn the patient and you have to use it for a shortest period of time. We have all used it in carpal tunnel at some stage. Not everyone agrees with that, but it is a common practice. Local sepsis is not a contraindication to using tourniquet, as long as you do not use S-mark or exsanguinator. We call it sausage. The reason is you don't want to drain the infection, the sepsis, beyond its location. Complications of tourniquet. Again, it is how do you phrase your answer, and one of the ways to do it is to divide it into local, distal, and systemic. So the local is skin injury related to pressure necrosis. Nerve under the tourniquet can be injured, and arteries can be either injured or thrombosed. Distal, which is more peripheral than the tourniquet itself, there will be ischemic injuries, thrombosis, post-tourniquet syndrome, hemorrhagic or intraoperative or post-operative, and compartment syndrome. And there are systemic complications as well. The post-tourniquet syndrome is related to the feeling of pins and needles and numbness and swelling and pain in the limb after the removal of the tourniquet. The most important thing you have to, which is all usually forgotten, is documentation and communication. And it's especially important when you are using a different type of tourniquet, for example, digital tourniquet, when you are doing like a digital surgery. Because you are not using an inflatable, you're using usually a rubber type. And usually it is, well, sometimes it can be forgotten or missed under the bandage. So it's very important to communicate with the team that it is inflated, it is deflated, and document the timing of the tourniquet itself. Now let's move to the next level. That was the SHO Mark 6 level for the exam. Now this is the next level up. Okay, so these are some papers and some very recent evidence that I hope you will find useful, which discusses the pros and cons of using a tourniquet. So although it is mentioned that it reduces the intraoperative blood loss, studies have suggested that actually the overall blood loss is the same, because once you release the tourniquet and you put a bandage, there will be some blood which is in the body that you cannot see and you cannot count for. So in reality, it does not reduce the overall blood loss. The recent evidence suggests that if you want to use it, You are using it to have a bloodless field so that you can operate. It is not to reduce the blood loss. And you have to weigh that carefully against the effects of it. There is another evidence here by Tosopoulos suggests they've looked at the quality of the cement in the total knee replacement with or without the tourniquet, and they've found that the quality of the cement is better by about 1 millimeter. So the average was 3 millimeter without and 2 millimeter with, sorry, the other way, 3 millimeter with the tourniquet and 2 millimeter without the tourniquet, suggesting that possibly it may give longevity. They followed their patients for about 2 years, and they could not find any clinical difference, but you know, that may pan out to be better in the very long term. Fine, so let's move on. The next topic I'm going to cover is draping materials. It is partially covered by the talk by Samir, so I would encourage you to go back and listen to it again. But in general, I will mention here that there are two general types of drapes that are used, either for your scrubs or for draping the patient, woven and non-woven. The benefit of using a cotton fabric is that it is reusable. So in hospitals in poorer conditions or poorer countries, or shall we call resource-challenged areas, it makes more sense to use that because you can clean it again and you don't have to buy and waste. And for people who are more environmentally aware, again, it makes more sense to use cotton fabrics. The benefit of the non-woven one, which is it has a smaller pores that should trap the bacteria and in theory provide more sealing and more protection against infection for both the patient and the surgeon. Having said that, WHO and NICE guidelines both say that both are effective and both are equally good in practice. So although we prefer in the UK to use the non-woven one, but it is okay to use the cotton one because it has a very good track record, and in theory they are equally the same. So you can justify it by using that in the exam. This is the only thing I wanted to add on this topic because it was covered really nicely by Samir. The only other thing I wanted to mention is the incisional drapes. The incisional drapes is the similar, what we call the IO band, which is the iodine impregnated sticky thing that we put on the patients on the field. And the theory behind it is if you stop the skin moving, you stop progressing of the bacteria from the unclean area into the clean area and then onto the wound. That has never been proven 100%. And although we continue to use it for whatever reason, but NICE actually recommends that we don't use it. And if we are going to use it, we use only iodophore impregnated, which is the IO band. WHO recommends against them as well, against both of them. Now, the reason they came up with that is, number one, there is no 100% proof that they actually work, and then it will cost money for no proven benefit. And you can think why NICE would come up with that. And WHO, because they have responsibility for, again, resource-challenged areas, so they have to come up with something that would make sense to everyone in the world. So again, if the topic comes in the exam, I would mention the theoretical benefit. I would mention that WHO and NICE recommends against it, but some surgeon would use a iodine impregnated, which is allowed by the NICE. So the next one is not actually an instrument, it's a process. So the question can come up in the exam. You've got a patient who is elderly, who has lost a lot of blood, and you are about to start him on a big operation that you expect them to bleed even more. So how would you think about stopping that bleeding or stopping the patient from bleeding to death? There are many ways of devising your answer or making it systematic. One way is to say steps that you do pre-op, steps that you do intra-op, and steps that you do post-op. However, I found this fine or nice way of devising it, which is assess, plan, communicate, and execute. So when you assess the patient preoperatively. How much is their hemoglobin, blood pressure, what is their cardiac function, and how much can they tolerate of blood loss? Are they on anticoagulations? And how much do you anticipate that your operation will make them bleed? Once you've assessed all that, you plan ahead. So are you going to use adrenaline? How would you correct the hemoglobin preoperatively? Are you going to give blood transfusion, or are you going to give iron, for example? Are you going to use autotransfusion? How would you adjust your surgical technique? Are you going to do it slightly differently, using of cement, for example, or not using for cement? Are you going to use a tourniquet? How would you correct the anticoagulation? And are you going to use tranexamic acid? Are you going to measure hemoglobin intraoperatively and blood pressure? And then once you've got a plan, you communicate that plan with both the scrub team and the anesthetist. And then you execute. And when you execute the plan you've mentioned, and then you focus on tissue handling and the use of diathermy. Now, the reason I brought this is my next topic will be the use of autotransfusion. So what is autotransfusion? It is a way of giving the patient their own blood. And the reason for that is you want to reduce the risk of getting transfusion from elsewhere with all the communicable diseases that can affect them. In addition, there are some religious groups that do not want to get any blood transfusion. So the way to do it, it is divided into a pre-donated blood or salvaged blood. And then the salvaged blood can be given intraoperatively or post-operatively. So this is how you structure your answer. You talk about the definition, the reasons for it, and the types of it. Now, the types of intraoperative autotransfusion, which is the cell salvage, in Ramachandran, he gave about 2 or 3 groups, but it did not make a lot of sense. I've found other sources, in fact, more than one source, that talk about only 2 major groups. And I think that makes it easier to remember. So unprocessed or unwashed method, or processed or washed method. And this is much easier to remember. The unprocessed or unwashed method is usually used post-operatively, which is types of intraoperative autotransfusion are divided into 2 in general. One is unprocessed or unwashed, which is historically the one that started first, and the processed or washed method, which is the newer one. So the older method is basically you collect the blood in the drain, you filter it, and you give it back to the patient. That's pure and simple. The benefit is it's cheap, easy. The patient has lost their blood anyway, and you are just giving them back that blood. The problem with that is you cannot give it to children. You cannot leave it for long. You have to give it immediately after collecting. And you cannot take a lot of it. And there will be other risks that I will be talking about in a second. The more advanced method, which is probably the method that the examiner would expect you to talk about, and in fact you may bring up yourself, is the washed method. Basically, it's a machine you tell the theater staff that you need, and then they will bring it to you to the theater. And then instead of using the suction and throwing that blood away, you use the suction, which has a special filter and an anticoagulant at the tip of it. And then that sucks the blood into a special container through that filter. And then that blood goes through a washing cycle with saline to try and get rid of all the broken hemoglobin, red cells, all the plasma. And then the red blood cells are concentrated, filtered again, and given back to the patient. The benefit of that is it is more robust. It gives the patient red blood cells from their own, and it reduces their need to have allographic transfusion. So the issues you need to know about is the patient has to lose significant amount of blood and be collected through this method because they get only 60% of it back. And what they get only is red blood cells. So they don't get any plasma or coagulation factors. So it is not cost effective in normal operations that the patients are not expected to lose a lot of blood. It is more cost effective in revision surgery, big pelvic surgeries, stuff like that. There is another issue. When you use the suction to collect the blood, just by passing through the inside of the plastic of the suction, the red blood cells get broken down through a process here related to the activation of the coagulation and complement cascade, which means, again, you don't get all the red cells, so you get only amount of it. In addition, you have to be careful during your suction, because you cannot suck small amounts. As soon as the blood is in contact with turbulent air during the suction, if you suck only a drop here and a drop there, it will be broken down. And if you, again, suck some clots, again, it has no benefit. So the only benefit of it is if you are applying the suction under a pool of blood and collect that. It is contraindicated when you are suspecting malignancy or sepsis, which is common sense. When you use topical antibiotics, again, it is contraindicated because the sample you are collecting will be concentrated even further and given back to the patient at a higher concentrations that can be toxic. We're talking about local antibiotics. We're not talking about general antibiotics. And whenever there is a topical, like a wound, coagulant factors, I think like Surgicel, or cement, because you don't want that to get into the bloodstream. The complications of the unwashed, which is the old method, which is just collecting a blood through the drain and giving it back to the patient, it can cause hypertension, hypothermia. It has been reported to cause ARDS, DIC, and even death. It can cause febrile reaction, and because the blood can be hemolyzed, in fact, it is some of it will be hemolyzed, it can cause renal failure, especially if you give significantly high amount of it. Okay. Now, if the other method of giving autologous blood donation is the patient themselves donate their own blood before the operation by some time, and that is stored for them. During that time, their body is producing more blood, and then that same blood is given back to the patient. The typical method for doing so is to take 1 or 2 units, the last one about 3 days before the operation. The patient has to have a reasonably good hemoglobin before that, and they have to have reasonably good health to be able to cope with the blood loss beforehand. So people who have cardiac problems, renal problems, you are suspecting that their erythropoietin is not going to be produced in a significant amount that would compensate for the loss, then you don't give that. And you don't give it when there is infection. Okay. So that's what I wanted to talk about. One more scenario that can come in the exam is the Jehovah's Witness. Now, the autotransfusion is not automatically accepted by Jehovah's Witness, although it is their own blood. Some of them would insist on having a full circle, which means the blood does not actually leave the cycle from their body. So the autotransfusion machine can be adjusted to accommodate that. And not all of them will even accept this. So in the exam, don't mention it like this is the answer. You mention that you would suggest this and discuss it with the patient, explaining that you are happy to make this adjustment to the machine if that would help the patient. Obviously, the discussion will go on then to discuss other methods like medical methods, erythropoietin injections, and preparations beforehand and all of that.
That's quite good. Just caution Jehovah's Witnesses, it's their right to say no to blood transfusion. And you need to know the steps you can perform to minimize the risk to the patient. And as Abdullah said, just to reinforce, this is not the panacea or the silver bullet that helps you manage treatment.
Absolutely. Good. Okay, moving on. The next process I'm going to talk about is image intensifier. You will mention that you will bring that to do a manipulation under image intensifier, and it's a fair game then to stop you and ask, tell me about image intensifier. Again, definition, what is it? It is a fluoroscopy system for use in theater. By that, it's an X-ray machine. Components are a C-arm, where there is an X-ray tube on one side and a receiver on the other side. This C-arm is connected to a computer with a control panel and a monitor to show the images, at least one monitor. So now you've defined it. You describe how it is done. So it is like your X-ray. There is photocathode converter on the converts that X-ray on the receiver to light, then detected by closed circuit video system, which is shown on the monitor. Okay. You should be able to describe how the X-ray machine, the X-rays are made, which is the vacuum tungsten, electricity, high velocity, and then hitting a tungsten plate. You should be able to describe that. But for the image intensifier itself, this would be enough. There are factors that would affect the quality of the image, and these you need to know about. What is the current, what is the voltage, and the exposure time, and how they affect the image you get. So the current, which is measured by milliampere, is controls the quantity of the radiation, the number of rays that you are getting. The more numbers you have, the better quality of your image. The voltage, however, which is kilovolt, controls the energy of each ray. So the more voltage you have, the more penetration you get, which means then it will penetrate more of the bone, and the bone would look like the normal tissue because it doesn't stand. Okay? The less penetration you have, the more contrast you have between the bone and the soft tissue. So that's the difference between the current and the voltage. The duration of exposure is what is described as the beam on time. And that is the amount of time you are leaving your finger on the button. So these machines, the fluoroscopy is not like a quick flash. It keeps beaming as long as the finger is on the button. And this is you need to be aware of. And even this is not, is not one radiation. It's a continuous radiation. The machine nowadays controls everything for you, so you get an automated calibration of the current and voltage depending on what the computer in the C-arm thinks is the best thing to show you the image. And that's why you don't have to adjust it every now and then. But you still have the ability to do so should you feel that you need to. For example, if there is a metal in the way and you want to see the images better. So this is a picture of the image intensifier, which we have all used. There are certain techniques that you need to be aware of. Magnification. When you do magnification, you are actually expanding the receiving end. So the source is the same, but the receiving is bigger. So that causes a bit of distortion, especially at the ends of it. You need to be aware of that. The opposite of that, or something slightly looks like the opposite, which is collimation or coning, which is you put a physical plastic at the source. So you are reducing the source area. By definition, then you are reducing the receiving end as well. So you're reducing the amount of radiation that the patient is receiving. The damaging effect of the radiation, it can be dependent on the dose, the rate, and the type of tissue, and the patient's ability to cope with that. So the type of tissue, the higher the, what's the word, sorry, mitosis rate, the more susceptible they are to damage. The more active DNA production, the more susceptible to damage. Hence, the developing embryo is highly susceptible. there is this definition which you may be presented with and asked to answer. What is stochastic and non-stochastic? So stochastic means that, sorry, non-stochastic means that there is a linear or a relationship between the dose and the effect. So the more the dose, the more the effect. And there is a relationship between them. Stochastic means there is no direct relationship. So you may have a small dose and that gives you big effect, and vice versa. And cancer is stochastic effect, especially long term, because even smallest amount of radiation can lead to cancer in the long term. The non-stochastic is things like burns and damage to the cornea and, you know, irritation and all of that. These are so the more radiation dose, the more you will feel these effects. One more thing, scatter is highest at the X-ray side. Hence, you try and put that X-ray side under the table so that all the scatter is away from you and the patient. Another factor that you will be expected to know is the radiation decrease according to the inverse square distance. So, and it is negligible by 2 meters. So 10 centimeter means that it reduces by 100 times. So it's squared. Okay. The most important thing you need to be aware of, which is the governing regulation for it, is ERMR, which is written there, which is short for Ionizing Radiation Medical Exposure Regulations. You need to pass that course before you are allowed to use SER. Hence, you are expected to know about it in the exam. It is not a complex thing. It is just telling you the regulations, the law that governs how you use this, and gives you actually, it's a useful booklet that you can, you can ask to download from your local radiology department, because it gives you some basic physics which you can use for the exam. The main thing is everyone has a responsibility to reduce the exposure to radiation, either as a prescriber or as an operator. And in the theater, you can be both. If you are having a mini C-arm, for example, you can be both. And again, you are under the law if you are if you don't comply with that. So the basic principle they are trying to advocate is the principle of ALARP, which is as low as reasonably possible, which means you give the patient as lower total dose as reasonably possible by the end of your examination. And in theater, that means as least, so the least number of images you take for the least time possible. And by doing these steps, which I would leave you to read, you can make sure that you're reducing the radiation. And again, this is an exam question. You can be asked, how would you reduce the risk of radiation in theater? I would stress on one thing that you may not find in many books, which is communication. You need to have good communication with the radiographer. You need to establish a rapport and a clear language to this, so that you don't do more X-rays than needed. No, I meant you go up, as in up to the sky, not up towards the head of the patient. And then the radiographer have taken 3 or 4 X-rays. So I'll leave you to read that. And then we'll move to the next topic. But the next topic is diathermy. Fine. The word diathermy, I tried to find, because at some stage I was really interested to find out where it came from. It's actually Greek, and it means through heat. Dia means through, passing through. And the reason is the electricity is passing and leaving the heat. And that's the diathermy. And the definition is the tissue heating effect when high frequency current passes through the body. The principle is if you focus a huge amount of electricity into a small area of the body, the amount of heat produced would have an effect on the tissue. And that effect can be either to cut, coagulate, desiccate, or damage. And then if you have control of that current, you can decide how that affects the body. Bear in mind, the same electricity that goes into the body comes out of the body at some stage, but it does not burn on the outside because by then it is distributed over a bigger area, bigger surface. And by doing so, it loses its intensity and then it loses its effect. And that's why it's very important for monopolar to have a bigger surface of receiver and make sure that there is no objection, nothing blocking it. Okay. Now, the current is alternative current AC, and it has 0.4 to 10 megahertz. These radio frequencies do not affect the muscles or nerves, so they do not cause twitching of the muscles or the nerves. You have to have way lower frequencies than that to affect the nerves. The heat is generated through Joule's law, which is the amount of heat in joules is double the current density, square the current density multiplied by the body's resistance multiplied by time. So the more fluid there is in the body, the least the resistance, which means the least the heat. Hence, the diathermy doesn't work underwater. The tissue temperature that can be developing at the tip of the diathermy is about 1000 degrees centigrade. But it reduces to 38 degrees only 1 centimeter away. And that is because it dissipates over a bigger surface. Now, there are two types of diathermy, the monopolar and the bipolar. We all know them. It's how you describe them in the exam. So the monopolar, you enter the electricity into the body in one side, passes through the body, and gets out of the body over a receiver that is attached to a part of the body, and then it goes to the machine. Previously, it used to be earthed, but now they go to a special machine to protect patients from difference in or problems with electricity. The plate has to be 70 centimeters square, and it has to have full attachment to the body with no hair or wet surfaces. Okay. It has to be put away from any bony prominences, scar tissues, metallic implants, and definitely away from the heart. And make sure that the current does not pass anywhere near the heart, especially if there is implantable devices. The bipolar diathermy, however, does not need that plate, and the current passes through the two arms of the forceps. So it is only in that area, and it has lower energy. So it's 50 watts compared to 400 watts for the monopolar. Now, let's talk about modes. We mentioned the cutting coagulation. There are other modes, and it depends on the electricity passing through and how they do. So the cutting mode is when you have pure continuous sine wave, all of them continuous sine waves, but here you have continuous and low voltage. And that produces high temperature, vaporizing the tissue, causes cell explosion, and then a gap appears. So that's the cut. And here you don't have to have full contact with the tissue because it's the heat. It's not the electricity. To coagulation, however, you have intermittent sine wave, but it has more power, and it goes on and then rests for a bit and then on again. Somewhere in between is fulguration, which is high voltage of coagulation that causes like an explosion of the tissues, which is a mixture of vaporization and coagulation. Desiccation is when you keep it in touch, but only using, so it's lower heat than cutting, so it dries only the tissue, and then it just coagulates. A blend is any mixture of the above. And just to describe it, if you look here, on the left-hand side is pure cut, on the right-hand side is coagulation, and the middle, it's a blend. And if you go further on the right, you will have the fulguration, which is even more bigger damage around the area. And these are the frequencies or the voltages of how they look. between coagulation and cutting. You can notice that if you look at my arrow, so for the coagulation, there is one wave and then a pause and then another wave, while in the cutting, it's continuous. How does what sort of things that would affect the function of the coagulation? Number one is the mode you chose. You can choose cutting or coagulation. You can, the more time you apply it, obviously, the more heat that will generate. The size of the electrode, the smaller the size, the more heat it produces. Tissue nature, as we mentioned earlier, especially ISCAR. ISCAR is like a charred, burned tissue, and it has very high resistance, which means it produces even more heat and more damage. Diathermy safety. Only thing I will mention here is there are 3 or 4 side effects or complications of using diathermy. We know about burns and fire, especially whenever you're using alcohol, and that's why it's very, very important to prevent any pooling of alcohol-based antiseptics around the body, because they can explode when you're using diathermy. The smoke of diathermy have been studied, and the CDC say that it contains many chemicals that can be toxic or carcinogenic, like hydrogen cyanide and benzene. In addition, it does not kill viruses. So viruses can transmit through the vapor of this diathermy. It can interfere with the ECG monitoring, EEG monitoring, and defibrillations, especially the built-in defibrillators in the patients. So always have a clear communication with the anesthetist beforehand. And in these cases, if you can avoid using the diathermy, do, but if you have to use it, use a bipolar instead, and use it as far away from the heart as possible. That's it. That's as much as, oh yes, NICE guidelines mention that you should not use diathermy to cut the skin because it would increase the risk of local infection. Remember this, okay? I think this is as much as I wanted to talk about it, and these are some references. There is a nice booklet which comes from ASSET, the Association of Surgical Trainees. It explains it in a really nice way. This is the link for it. Any remarks, you guys?
That's interesting. You found that nice guidance saying don't use diathermy for skin incision.
Pressure irrigation. So, what is pressure irrigation? It's a method of delivering irrigation to the tissue under high pressure. So, the way we irrigate the wound can be divided into low or high irrigation, high pressure irrigation. Anything between 1 to 15, forgot the unit, pound per square inch is low pressure, and anything above 15 is high pressure. And there is some people divide it into low, medium, and high. Usually, when they say high pressure, they're looking at the pulsed lavage. This is what is commonly known. But by low pressure, we are talking about using a syringe or pouring of normal saline, or just giving it through a giving set with gravity assisted. So, what is the benefit, so the difference between using the two? So the low pressure, you usually use it with a brush or a scrub to try and clear the wound and reduce the amount of debris. So this is gentler to the tissues, and some studies, like the one I've mentioned here, Draeger and Danners, suggest that actually you remove more debris through the low pressure than high debris. And it does not cause any damage to the tissues, including the healing bone. The high pressure method, the advocates say that it is more powerful and can relieve a lot more debris from the wound, including bacteria. And advocates suggest that. They have done some studies, including beef meat. They have put some bacteria into it and tried and cleaned it with either method, and found that the bacteria removed more with the pulsed lavage. You could look at the paper there. Having said that, there is a new evidence. This is an international multi-center study, new, I think it's 2019, no, 2020, from Canada. They've looked at two things. They have looked at the type of pulse, of pressure, so either high pressure or low pressure, and they've looked at using normal saline versus soap in open fractures, and they looked at the amount of clinical reoperation as indication of infection rate. And they found actually that low pressure is better. It gives low reoperation rate. And the explanation could be because by damaging the tissue, you are actually pushing the bacteria and the debris deeper into the deep tissues, and then they rebound with a bigger infection. So this is the new study which you would be expected to quote in the FRCS exam. So what is the bottom line with all the evidence, conflicting previous evidence, and this big study which only looked at open fracture? It did not look at elective cases. It did not look at chronic infection which, for example, in limb reconstruction with osteomyelitis and how you wash it. They looked specifically at only open fractures. So how would you take that into practice? A pragmatic way is not to use it for open fractures or for normal cases, and use it only if you are clearing an ongoing infection like a osteomyelitis. Okay, and concerning the additives, they found actually that the soap gives more rebound of bacteremia compared to normal saline. So NICE guidelines suggest the following, and this is what we should be following, and this is from 2008. Do not use wound irrigation, do not in lavage, and do not apply antiseptic or antibiotics to the wound before closure. And this is what you should quote. So this is just a bit of some information to start you talking, to organize the thoughts in your head. Plaster of Paris is calcium sulfate with water. It's cheap, non-irritant, easily applied, malleable, and radiolucent. It is made by heating mined purified gypsum at 120 degrees. It allows partial dehydration, and then it gives it its properties. Recently, or from the 70s, benzalkonium chloride is added to increase its properties. Once it's mixed with water, it produces heat, and then it becomes a porous mass. And porous is an important word here. The reason is it allows some breathing of the skin. So the skin underneath it is losing a bit of heat through the porosity of the plaster. It needs about 36 to 72 hours to completely dry, but the patient can start working on it if it's a full cast in about 48 hours. There are two stages like cement, the setting stage and the hardening stage. And the quality of your plaster is determined by, the quality of your cast is determined by the quality of the plaster material, the water to gypsum ratio, the age of the gypsum, and the storage conditions. The more wet it becomes, the less effective. There are almost no allergic reaction to plaster of Paris. Once you've talked about it, you talk about certain techniques and how to apply it. So you always put a padding of a sufficient thickness, not thick enough, not too thick to lose reduction, and not too thin to allow heat to get to the skin. You roll the plaster bandages, you don't pull them. You allow them to dry naturally. The heat is produced depending on the speed that it dries. So the faster it dries, the hotter it becomes. So that's one reason for you not to dry it with a, I don't know, like a heater or something. There are some reports of burns coming from because of the plaster. The fiberglass cast is a synthetic material. It's called glass reinforced plastic. It is polymer with glass in it, okay? And it comes obviously in different colors. It is stronger than plaster and lighter, but you cannot use it as the first time, cast, because it does not allow for swelling of the body. Complications of casting in general, you should know them: DVT, compartment syndrome, swelling and subsidence leading to loss of reduction, pressure sores, we've seen it, venous congestion, and disuse symptom, which is related to stiffness of the joints, damage to the tendons, muscles, and skin. Sterilization techniques. This is a complex topic. You might be expected to describe what happens if you drop something in theater and you want to clean it, and then how would you clean it and what would you accept as a cleaning method? Or what do you think happens to the instruments once they're sent to the SSD? So all these are fair because it has bearing on your work. So in general, we divide items that the patient used into critical, semi-critical, and non-critical items. The critical items are ones that are in contact with unprotected parts of the body. So they should have no contamination whatsoever. The semi-critical are in contact normally with normal parts of the body, like a mucosa, okay, and intact skin. And which means they have to have protection, but it doesn't have to be the same level. And then the non-critical are anything that patients use, like clothes or medications or stuff like that. They're not in contact. So for that, we have different levels of removal of contamination. So you have cleaning, which is just removal of the dirt, but specifically removal of bacteria. You have sterilization, high-level disinfection, intermediate-level disinfection, and low-level disinfection. And you will be expected to know the difference between them. Basically, sterilization is when you remove all bacteria, viruses, fungi, and more importantly, spores. The high-level disinfection, you remove everything but spores. The low-level disinfection, everything but you don't remove myobacteria or spores. Okay, all of them are disinfection. Cleaning doesn't remove any of these. It's just visible dirt. Okay, you could look at this summary. It's a really nice paper summarizing all of that. The WHO document has a really, again, nice document talking about how you sterilize, how you set up a hospital with a sterilization unit. There are some aspects that apply to us. For us, what we need to know about is the mainstream of sterilization. Our instruments is the autoclave. It should be disinfected first and cleaned before sent to SSD. The reason is we want to protect the staff there. It is left in the autoclave for 20 minutes at 121 to 132 degrees, or for 30 minutes if they are wrapped packed. And there are some indicators they put in the machine to indicate whether it has done its job or not. The dry heat is not as effective as autoclave, but it is applied to 1 to 2 hours for 170 degrees. And again, they have to be cleaned beforehand. This is poor alternative, but sometimes the only alternative in some settings. Boiling itself is not good enough. Antiseptics is sometimes used, like glutaraldehyde or chlorhexidine. Especially they put like a small desk with the instruments and they leave them. This is usually used for things like the drills and machines that have multiple mobile parts. Flash sterilization is a new technique. It's not that new, but it's new. It's a modification of the conventional steam sterilization, whereby it is put in a container, rigid container with its covering, and then it is allowed to quickly clean. And this is usually used when you are in need for you dropped something and you want it cleaned very, very quickly. And they call it the quick cycle. So if you speak to your SSD, this is how they do it. but they don't advocate it for routine use. It is something only for emergencies if, you know, if it is needed. Okay, there are some chemical methods like ethylene oxide, ETO. This is something that is commonly used, so we probably need to know about it. It's odorless, flammable, and explosive. And it is the machine, sorry, the instruments are left with it under heat. And then once you move the machine from that, once it gets exposed to air, it loses some of its sterility. The way it works is it's alkalization of the proteins. Hydrogen peroxide with plasma is as effective as the other one, and it is used usually for electrical components. Last one is ozone or hydrogen peroxide with ozone. It breaks down into oxygen and H2O by the end of it, and the duration of the cycle is about 4 hours and a quarter. It is used for many, many materials, but it's not used for brass, aluminium, liquids, textile, and cellulose. And that's it. I hope I did not send all of you to sleep. I hope some of you are still awake. Anything you would like to add, guys, on sterilization?
Actually, I have a question, Abdullah. Do you still use flash sterilization? Our trust has taken that out.
I did not ask our trust, I have to say. But last trust, I know we have a rapid cycle, and I assume that it is the same. Because we dropped an instrument, and we needed that, so they did that quickly.
What's the best management for tourniquet palsy?
It depends on the cause. Usually it is neuropraxia, usually, which means it will come back alone on its own. Having said that, the usual practice is you check the patient, make sure that it is that, not something else that you've cut during the operation. And then you leave it for 6 weeks, and then you do nerve conduction.
Absolutely. So, for example, in the knee replacement, a patient then gets a perineal foot drop.
Of course, splints.
Think a patient putting splints on. Think of the cause of this perineal foot drop. It's often not the tourniquet, so look for other reasons.
Don't assume it's the tourniquet.
And there's a reason why the tourniquet is always put on the fleshiest part of the limb. It's to avoid the nerve injury. Okay.
Interesting about the tourniquet. Can you apply it to the lower limb, as into the lower leg or the forearm?
In foot and ankle, they apply it to the calf.
Yes, they do, but it has less efficacy because of the interosseous membrane protection of some of the vessels there, which cannot be blocked.
Absolutely. Okay, is there any other questions?
Okay, inappropriate, and you do not have another. How to deal with one important instrument fell down, intraoperative, don't drop it. No. Well, you have to think outside the box. The thing is, it depends on what sort of instrument you are. If it is going to stay in the patient, it's an implant, then, you know, either you delay the operation or you are putting an implant which has substandard and could be contaminated with long-term infection problems. So it's a judgment call. And I would personally, if it's an implant, I wouldn't risk it. The patient can always come back later. But the idea is in planning. Why are you having only one implant in the whole hospital? And then you drop it. I mean, yeah.
So, yeah, I don't know what the other mentors, if this came up in the exam, dropped instrument, or more importantly, you have one set of an instrument. My response is always, I will ask for another set of instruments to be made available to me, either from another hospital or from a company before I endeavor to take on this procedure, so that I have a backup set of instruments in case one fails or breaks, two, dropped, three, the sterilization procedure is compromised. You open a pack and you find the patient is on anesthesia, you've opened the pack and it's been compromised with a hole or something like that. So there are multiple reasons why you shouldn't have only one of any instrument. I would not say things like, I'll give it a quick rub and push it, put it back in, or put it, dip it in alcohol.
No.
Don't
One thing, the examiner may want to know about your knowledge of sterilization, and then he will give you the scenario, and whatever answer you give him, he will block it for you. The only thing he wants to hear is whether you send it to SSD and what they will do with it. And then it will not be something that you would leave in the body. It will be a vital instrument, like, I don't know, for example, the implant holder or something that you have only one set of, and it's dropped, and you cannot hold the implant or orient it or something, but it's not staying in the body. Then what will you do? So I think that's what you are alluding to. And if that is the case, then you can say, I will send it for a flash sterilization because we have, rapid cycle in our SSD if they can't find me an alternative.
Absolutely. But it's, I'm not, that's a very reasonable thing to say, but kind of don't just say, because it's not something that should happen. Does that make sense?
Okay.
It's something that should be detected. If you're dropping something and flashing it, you should be reporting it as a potential problem. And even in terms of GMC guidance, you should be also documenting it and reporting it to the patient and explaining what you're going to do to make sure the patient doesn't have consequences, managing the patient, but also what you're going to do to make sure this doesn't happen again. So it's not, this is not an easy question, by the way. It's not a simple put it in the flash.
No. We are saying it like that, but it's not. No. The whole thing is, you always start by saying, the best thing is in planning. I should have planned to have alternatives beforehand. And he said, yes, you planned, but all of them lost sterility and whatever. And then it's like giving you the tumor question. You don't immediately say, I will do this. You have to give all the right steps beforehand. So you planned, you made sure that it's available, you asked about other alternatives, you asked in other hospitals, you brought a consultant next door and asked him, this is the situation. Do you have another instrument that you know how to use that could replace this one? If all of them are not, then yes.
And the final one is, so one example where they can put a lot of pressure on you is, say you've 3 small fragment sets, you've opened all 3 of them, each one has a hole in the pack and is not sterile. What do? Don't say you're going to operate on the patient with a non-sterile set. Either wake your patient up and come back later, or get flash. And if you have to get flash for an ankle fracture, you might as well wake up the patient and do it.
Absolutely. The only reason for you is the patient is critical, and there is no, the harms of delaying the operation are by far more than the harms of operating with a flash sterilization. And then, but then you include another consultant with you. So that's what you tell them. I will include another consultant in the decision making.
Absolutely. Yeah, that's very true. Thank you.
Thank you very much, guys. I hope it was useful. And if you later on develop any questions or have anything, just put it on the Telegram group.
So thank you, everybody. Abdullah, really appreciate you, first of all, just unscrubbing and coming straight away to do this. I know you're first of all tired and probably very thirsty and hungry. And I know you have a long trip home. So we thank you so much for coming.
No problem. In fact, if that is the case, may I excuse myself and just disappear, and I leave the guys in your hands.
Very upset if you don't. And once again, guys, the mentor groups, thank you to the mentors, Nikki Evans and Hania Bardasi. And also a reminder, we have published the concise orthopedic notes. New improved edition is there. So please reference that book if you can for your studies. We think it is in your best interest, and that's all we're interested in.